So we're really delighted to have one of our newer faculty members, who's the Associate Dean for Research at the College of Nursing. Hyochol, he goes by Brian on. Brian has a really fascinating background. He's one of the most multidisciplinary people I think I've probably met so far. So he actually started with a bachelor's in electrical engineering at University of Seoul in South Korea in 1997. He then went here to the United States and got a Ph.D. in engineering at University of Florida in 2006, and decided, and I don't know the backstory on this, perhaps he'll let us know, decided he had a strong interest in nursing, and so eventually picked up his Ph.D. in nursing, also from UF in 2012. And he really seems to like degrees because he also picked up an additional MS degree in medical sciences in 2015. Near and dear to my heart, he's also got a graduate certificate in aging and geriatric practice that he picked up in 2016. And he finally came to us this past year in the College of Nursing. He's got a very interesting, given that background is not surprising, he's got a very interesting research background. His real aim, as he puts it, is to enhance health and independence in vulnerable populations. And to do this, he uses a series of innovative technologies, and his interests are mainly on optimizing pain and symptom management. And his combined nursing, medicine, and computer engineering expertise kind of uniquely positions him to address critical gaps in research on things like brain mechanisms underlying pain and other chronic symptoms, and to deliver non-pharmacological intervention to improve pain and symptom management. And he's worked on a number of different projects, identifying things like biopsychosocial determinants that influence pain and disability, developing pain management interventions and assessments. He's been continuously funded since about 2011 as a PI with almost $4 million in grants, and has produced more than 120 peer-reviewed publications and presentations. He's also served as a grant reviewer for several study sections in NIH, DOD, Department of Veterans Affairs, and is grant director at the Southern Nursing Research Society. So we're really pleased to have Dr. Brian, oops, sorry, I have to cancel something here to make sure I don't get in the way of things. Dr. Brian on to talk to us today about feasibility and efficacy of non-invasive brain stimulation for self-management of clinical pain and symptom management. So take it away.
Thank you very much for a very thorough and kind introduction, Dr. Charnes. And let's get to the topic because we have limited time and I have lots of slides to share, a lot of information. So the title is the Feasibility and Efficacy of Non-Invasive Brain Stimulation for Self-Management of Clinical Pain and Symptom Management. And for today's presentation, Dr. Chan has already shared my education background. So I will briefly touch my training background and then principles and evidence-based guidelines of TDCS, and 3 completed project about TDCS and my current NIH project as a PI 3 project. And actually, as of now, I have 10 other transcranial direct current stimulation that is not only for the pain, but the other symptoms. So I will share that. And lastly, I will share that brain stimulation and imaging laboratory we set up and is running at the Innovation Park. So Dr. Chan has already mentioned about my degrees in electrical engineering and computer engineering, nursing, medical science. And then I've got research training at the NIH, NINR for the Genetics Institute program. So I will use bad genetic component as a part of biopsychosocial mechanism. And also I'm the certification of NIH National Center for the Neuromodulation Rehab, and I'm the advisory board for the TDCS design class. And also I got a visiting fellowship from the Harvard MIT MRI program and the multimodal brain imaging and functional near-infrared spectroscopy. So I will use most of the research in the brain imaging in addition to brain stimulation, because we would like to see how this brain stimulation affects brain imaging. So we are knowing about hemodynamic and the functional connectivity of the pain and symptom related brain network. So the brain is an electrochemical organ to process pain and the other symptoms, and brain makes constant use of electricity to rapidly convey information via action potentials centered along axons. So all the brain stimulation comes from this idea. So most of the symptoms like brain-related symptoms, we call it symptom cluster, such as pain, depression, anxiety, sleep, fatigue. Those are brothers and the sisters of the symptoms. Each symptom negative feedback the other symptom. For example, if you have chronic pain, you are easily fall into depression. And depression, you have anxiety. For these kind of symptoms, you cannot sleep well, and it gives fatigue, and you will have a lower quality of life. So especially NINR, the National Institute of Nursing Research, calls symptom clusters, and they are analyzing this one as together. Two major topics, types of non-invasive brain stimulation is TMS and TDCS, and currently FSU are one of the frontiers of these stimulations. So Neuromodulation Center, chaired by Andy Kozel, Kevin Johnson, they are focusing on the TMS. And my brain stimulation and imaging laboratory, we are focusing on the TDCS, but we are collaborating each other. I've known them more than 10 years. We are working with similar topics by collaborations. So first, briefly, I will share the TMS. And TMS is called transcranial magnetic stimulation. As you know, this is a transcranial. It means that they are stimulating whole brain and using magnetic field stimulation. So that there is a very, so you can see this picture. This is a TMS. It's a very big kind of machine because it is using magnetic field. So it's like a big kind of machine like an MRI. MRI is a magnetic resonance imaging. So for the magnetic changes, it needs a lot of noise, a lot of big equipment, and it gives that direct like a brain stimulation in the head. And the TDCS is, this is a small device like a cell phone size, is a home available, home intervention. So it has, both of them doesn't need any anesthesia, and the person will awake full time during the treatment. Both of them doesn't need several interventions required over several weeks. So sometimes 4 weeks. So TMS are like a 6 weeks program. So, and the major difference is that TMS equipment is not portable. So at this moment, home-based intervention is not possible. I don't know future direction, but that is the current status of the technology. And the side effects of TMS is very mild and negligible, but it includes muscle contraction and tingling and headache, lightheadedness and facial twitching. Like an MRI, it does give a lot of noise, like a do beep 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 beep, do beep 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 beep, do beep 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 beep. They are kind of changing their magnetic field to change it about the H2O. So they need to separate hydrogen and oxygen. They can see those kind of brain pictures, and TMS has a similar technology. So it gives a lot of noise. Several kind of noise, and many older adults do not like that noise. Instead, the TDCS is a very non-invasive, painless, non-noise, and it's just like you can watch your screen so that there is no noise, and also it doesn't need any big device. As you can see, that device again. So this device is a cell phone size, iPhone size, and this is huge size. That is a major kind of difference. So, and it's like a chip, like a TMS, usually like 30 to $100,000, and TDCS it varies, but mostly commonly used Soterix TDCS device is $3,000. So $3,000 versus 30K. And also TDCS is portable, so home-based intervention. Nowadays, most of the TDCS research is based at home. And the side effect is minimal, only itching or tingling. The scalp is very minimal, negligible. So I think the major difference is it is portable and it is a home-based intervention. Especially COVID situation, both of them needs several weeks continuous stimulation. So brain stimulation in late term is a brain massage. So we need consecutive days of intervention. So that is a TMS is some kind of draw cons of that intervention. But I don't want to reduce the importance of the TMS. The TMS developed it earlier and FDA approved kind of intervention. So many depression or pain, they are using the TMS, and TDCS new emerging intervention. So it's better for the research because we do not know it is working or not. So it is not approved for clinical use yet, but TMS is now clinically approved. So you can see some TMS clinic over the US, but there is no TDCS clinic yet. So lots of grant money for TDCS to find out its clinical efficacy. So also TDCS, I'm focusing on the pain because I'm especially focused on pain medicine as a pain specialist, but it is not used only pain, but also any brain-related symptoms. So that that the international group, the neuroscience expert, recently published evidence-based guideline for the therapeutic use for the TDCS at the clinical neurophysiology. So since we have evidence-based guideline, theoretical framework is very strong. So for the research use, as you know, that conceptual framework, theoretical framework important, and it is based on these kind of guidelines. And it is also used for Parkinson's disease, motor problems, the motor symptoms of Parkinson's disease, other movement disorders, stroke, aphasia, multiple sclerosis, epilepsy, consciousness, Alzheimer's disease, tetanus, depression, schizophrenia, of substance abuse, addiction, opioid use, and other psychiatric disorders. And now it has several kind of do-it-yourself DIY approach, and the neural enhancement and brain imaging, they are combined each other. So I think that it is a very timely intervention. It's one of a very hot potato topic at the NIH perspective. So based on the guidelines, they give some kind of important kind of thing for the placement and the dose. And still placement is somewhat agreeable nowadays, but dose is changing because like other non-pharmacological solution, TDCS, that effect is varies. And many people think about that is due to dose effect. What is a recommended dose? Like it depends on the severity of the symptoms. So let's say if you have a Tylenol or ibuprofen, that is the first line of therapy for the osteoarthritis or the other kind of painful symptoms. But that dose is somewhat varies, right? You can take that 500 milligram Tylenol once a day, then your pain is gone. Some people take the 2 tablets, or like, in other words, 1,000 milligram, not 500 milligram. And they are taking how many days? It depends on the people. So this dosing effect of TDCS is in the lens of precision medicine. There are lots of like a discussion right now. And recently there is RFA for the neuromodulation techniques for the pain management. There are several RFA and the PA based on the HEAL initiative or brain initiative. There are multiple multi-million or somewhat $1 billion kind of RFA is published in the past, like 2 or 3 months. So I will share my first TDCS project. It is funded by NIA, Cloud Pepper, OAIC program. And that time I used a clinic-based TDCS that is 2006. So it's on, no, 2016 or 15. So it's almost like 7 or 8 years ago. That is a laptop size of TDCS. The first important thing is that TDCS got immediate attention from NIH because, for example, like TMS or the other non-pharmacological solution, the big problem is a sham intervention, the comparison group. So let's think about yoga therapy. One group has a yoga, the other group has no yoga. So then patient or experimental blinding is not very strong because the patient who do not yoga, from the informed consent, they know the title of the project. So they can guess they are not in the experimental group. Or the instructor of the yoga, they know who is doing yoga therapy or not. So the possible blinding is data collector or statistician blinding. So that is somewhat blinding mechanism in there, but it's not very strong. But for this TDCS, we are using the keypad. The keypad number, we don't know. The keypad means like a 5-digit keypad password. We don't know it's experimental group or active group. Only statistician knows about it. So totally it's a quadruple kind of blinding is possible. So participant, since they got this number, they do not know what it means. Even the operator of this machine, they do not know it's a sham mode or experimental mode. And of course, the data collector, they do not know, and the statistician does not know. So it's a quadruple blinding. That is a huge advancement for the randomized control trial. And then I chose especially the osteoarthritis pain because as a pain specialist, I don't know that knee osteoarthritis severity that is confirmed by knee X-ray. But the important thing is knee X-ray evidence for the osteoarthritis severity is not matched with the patient complaints. In other words, we see that advanced osteoarthritis status, but some people do not complain that pain that much. And we, vice versa, we did not see any X-ray evidence of the osteoarthritis, but some patient complains a lot of their pain and disability. So I'm very curious, how does it come from? Why? This is the definite a diagnosis tool as a knee X-ray. Why this X-ray evidence is not matched with the patient complaints? So that time I'm thinking about, oh, maybe there is some other mechanism. So knee itself is a peripheral mechanism. Those kind of knee nerve connect to the spine and eventually goes to the brain. So those kind of central organ, which is the brain, has some function in these complaints. So that's why I'm thinking about some non-pharmacological intervention focusing on pain-related brain function. And also using my computer science skills, I'm very good at brain imaging analysis and those digital pattern recognition. So that is one of my past knowledge. So I'm using my past computer science skills in this analysis. So that's how TDCS kind of developed it. And the conceptual model is if somebody has a chronic pain, those kind of chronic pain affects pain-related brain function or connectivity, and it elicits pain. So TDCS affects this clinical pain through the brain function, and we can see those kind of mediating effect. So my first project is a single center, double-blind, randomized control trial. And we chose a very short period, so 6 visits for 5 consecutive daily sessions, Monday through Friday, just 1 week, and weekly follow-up, and I recruited 40. So that all the adults with the knee osteoarthritis pain, but we exclude if they have some other painful conditions that can confound the osteoarthritis conditions. So we use esoteric TDCS, only statistician able to unblind data collection and those groups. So we follow the evidence guidelines of that neurophysiology group, and the sham intervention is that keypad. So we put some keypad. We don't know is what is the experiment group or what is the sham group, but we know that sham intervention is that exactly same everything except those kind of intervention, the first 30 seconds and the last 30 seconds, because the TDCS is 20-minute stimulation, so that they feel some tingling sensation. So because of that electrical massage started, there is a tingling sensation to mimic those sensations that sham stimulation, the first 30 seconds, they feel some tingling sensation with the same severity. So in other words, they think, oh, something is going on. I feel some tingling sensation. So probably I'm in the TDCS group. And also when it finished in the last 30 seconds, it gives another tingling sensation. So the front and back, they feel the tingling sensation. So they think that they are getting TDCS stimulation. What a wonderful kind of sham intervention. So that patient can blind very good level. And based on the literature, that sham group cannot differentiate that they are in the TDCS or sham group, they cannot differentiate that. So we also measured the experimental pain using like a computer controlled kind of devices. We are measuring hip pain threshold and tolerance and the pressure pain and the punctate mechanical pain. This is the first randomized control trial TDCS in the pain. So that's why I got the first submission. I got the NIA award at the first submission. That is not very commonly happen in many research grant submission, as you know. And so since this is the first TDCS trial, we are monitoring all the possible side effects. And we recruit 43, but 2 people does not want it. And the 41 randomized 21 and 20, 1 person withdraw. And in the last time, 20 completed active and 20 completed sham. So they are somewhat, 60 years old on average, and the female, more female than male, and the white and minority is and half, because we are focusing on the minoritical kind of representation, and BMI is somewhat obese as we expected. So there is no difference in this group. And we found that this blue is a sham group, and this is red line is a real TDCS. As you can see, the first trial, we can see both of group that clinical pain score is reduced, and it's very true because there is a placebo effect of pain management. Pain is 0 to 10. 10 is the worst. How could you rate your pain? So that this placebo effect is kind of expected, but we see there is a big difference of these pain scores. And most importantly, those placebo effect will be gone after intervention. So that this pain study, follow-up study is very important because it is one way to see if there is a placebo effect, yes or no, and we found a significant result. As a pain specialist, and I'm the chair of the several study section, NIH, DOD, and the VA, my recommendation to any pain program, I see lots of critique if there is one group open label study, because as a pain specialist, we do no placebo effect. So if there is no randomization, there will be critique. So even this pilot study, I try to have 2 groups randomly assigned, and also to prevent those placebo effect, those follow-up studies, even like a short period, we need that. And that's, I believe that's why I got almost a perfect score at the first submission. And we found the significant differences. And we also see the mobility score, but it's not significant, but the direction is the same. Sham group, small changes, but active group, huge changes. Sham, active, minus 0.2, minus 0.6, and the impairment, like they do not, any changes, a very small impairment is increased rather than active group is reduced. So, and the 6-minute walk, that is a 6 minutes, we ask them to walk as many as possible. And we are measuring those meters, so that is a sham group only 3.6 meters, and this is 16.3 meters. But p-value, as you know, p-value has some bias for the small sample size. So this is small, but in the effect size is kind of moderate effect size. And not only those kind of, these measure pain self-report has a lot of bias or placebo effect. This one is also subjective kind of questionnaire one, but this is a walking test, a little bit objective one. And now we have a biological marker, which is definitely objective kind of measures. So because the patient cannot change their biological markers, and we are measuring interleukins 6, 10, TNF-alpha, CRP, cortisol, beta endorphin, and BDNF, and brain-derived neurotrophic factor, which is at this moment is very close to the pain biological marker based on this current literature. And we found that those significant changes. And also experimental pain is also changes. So, and we did not find the big side effects about the fatigue, nervousness, headache, difficulty, concentrating, mood changes. It's all kind of no side effect at all, but some people has some tingling sensation. That is what we expected. So this is the first study, randomized control trial study to test the efficacy of TDCS in knee osteoarthritis using double-blind randomized sham-controlled design. And we found a significant reduction, numeric score of knee pain, the active group. But as you know, it's a 40 people, small sample size, and there is no longer term, it's a week 3 kind of follow-up. And since it's small sample size, it does not show all the changes, positive changes. So the long-term efficacy cannot be established. So this one gives us the future direction, and it leads to the NIH grant. So that the take-home message is that it's a first study, and TDCS did not cause any significant side effect. And the future study is a home-based one, because one of the qualitative approach, we found that patient complains about their time, their transportation. So they think, oh, 5 days in a week, every day, just for 20 minutes brain massage therapy to your clinic from my workplaces or my home is very inconvenient. So the patient suggested some way of remote kind of technology, home-based intervention. They suggest that. And it gives the food thought for my future R1 and R15. So this is all home-based intervention. And these studies are ongoing right now. And I move all the grant money from my previous institution to the UT Health. So that's why after this study, I found that, oh, the patient do not like the clinic-based one. Again, every day, 1 week, 2 weeks, even 3 weeks, 4 weeks, they come every day, especially depression in this minimum kind of stimulation is 4 to 6 weeks. So think about the older adult come to the clinic every day, Monday to Friday, for 4 weeks, 6 weeks, almost impossible. So now we are developing this home-based intervention. Keypad is a key thing, so we program it, and they are using at their home, using this Zoom or HIPAA-approved remote technology. So this one is one group open label study. I told you that pain study should be like a randomized control trial. But why this is one group? When I talk with my program officer, NIH, I subsequently submitting my R1 study based on that study. But when I talk with her, I told them, oh, wow, we found a very significant and promising result, but patients do not like the home-based, patients do not like a clinic-based intervention because they cannot come every day. So they suggest a home intervention, but I do not have a clinical data, pilot data. What is your suggestion? And she said, yeah, in that case, just quickly get like open label study so that you already show that TDCS efficacy using a randomized control trial, so that just to the open label study. That's why I did that So take-home message here is that program office is your friend. So they usually lots of advice. I'm always sharing my specific aim page and my bio sketch. Now I know her more than 10 years. I do not send my bio sketch, but I will send the specific aim page, and I'm kind of talking with her. So get some kind of ideas of how can I promote and the progress in the future. So this TDCS brief training is we have all the instruction manual with the pictures and minimally burdensome. So I don't know this chat box, but somebody read for me if there is something I need to take care of it now. Otherwise, I will keep going. And this one is like the patient-wise only on and off button. They click that and it is just automatically start and the device turn it off automatically. I can go this out. Probably it will bother your the slide title, but I don't know. Oops. Okay, so participant is older adult with a neoarthritis pain. So we are having similar target population and open group, and this is 2 weeks, 10 sessions. And we recruit 23, 2% doesn't want, and 21 and 1% withdraw before intervention begins. So all the 20 people completed. So that similar age is 60, around the 60, female, and some white, some minority, and their baseline pain score 55 out of 100. So moderate level of pain. Osteoarthritis duration is 31 months, roughly 2.5 years. So we pre and post design, the numeric score is 55 to 24, and the OMAC pain 7.9 to 5.7, and also experimental pain, it is increased. So it's all good data. Found that patient satisfaction, because since this is the first remote technology home-based intervention, I want to make sure patients feel comfortable to use this. And they said overall the device was easy to use, 0 to 10. They got 9.6. It's easy to prepare the device and exercise, 9.6. So that it means that they like our intervention. The effectiveness treatment increased over the course of treatment, 0 to 10, 6.8 is good, because we have a half is a sham group, half is experimental group. It means that they really do not know they are in the sham group or experimental group. So this kind of result all supporting this home-based intervention. We also use that FNR's brain imaging so that we found all the brain hemodynamic activities and the functional connectivity changes. So this is the first study to do the home-based intervention with the remote technology. We found it is promising. So then I did another study about combining intervention with the TDCS with mindfulness meditation, because the TDCS itself is a neuroplasticity, so it enhances brain activity to reorganize in response to other clinical intervention. And mindfulness-based meditation, it also changes pain relief brain function. So pairing this TDCS and the mindfulness meditation, we want to see the synergistic effect. So we are combining and we are measuring all the pain relief brain function and the clinical pain. And this is the first synergistic effect of TDCS and the mindfulness meditation. And we recruited 30, 15, sham group 15, active group, and it's a 2 weeks intervention. And we randomly assigned 30 patients, 15 to active, 15 to sham group. and we found all the significant and see the effect size is a really huge effect size. So we can see those kind of synergistic, kind of amplified kind of response. And also they feel it's easy to use, and we show that it's promising. So it goes to my R1. So my current study right now is R1 study, and we are in the year 3. So that since it's all home-based intervention, we do not have any patient recruitment problems, which is many studies has stumbled with that. So NIH really liked this home-based intervention. It's $2.4 million, is up to 2025. And recently we complete this data collection about the 20 sham active group for 3-week trial and monthly follow-up. And we are doing data analysis, and we are submitting this manuscript really soon, but we found a significant result. So it feeds my other studies right now. And also important one, and I have several advertisements by Dr. Neil Charnis helps advertise our study. My real, oh, not this one. So for this dementia study, right now, dementia pain management is a really big problem. The dementia has a cognitive impairment and communicative impairment. 0 to 10, 10 is worst pain. How could you rate your pain? They cannot respond. So we cannot really treat the pain in the dementia. And from other studies, we found that this untreated pain elicit the behavioral, psychological symptoms of dementia, such as aggression, agitation, nervousness, some wandering. So we got this supplement grant, and we completed 20. We already, by the interim analysis, we see the significant changes, but NINR wants to complete this 40 people because they think 20, we just 20 group 10, 10. So they think that central limit theorem is a little bit low level sample size. So if I really go to the R1, they recommend to complete 2020. So they lengthen. So that is a 1-year study, but they extend our study period in the 2022 in July. So we would like to complete this study, and then we will go to the R1. So I really focusing on this dementia pain management. This is my PhD dissertation. So, and this is 12:44. So I have roughly 6 minutes. My goal is to finish my presentation, 12:50 and 10-minute Q&A session. So briefly, I want to share my lab. And so, as you can see, the brain is a central electrochemical organ to process many clinical symptoms, specifically pain, PTSD, dementia, depression, anxiety, apathy, fatigue, sleep, cognition, mood disorders, neuropsychiatric disease. So I'm doing this study by collaborating with the other university colleges scholar, and we have all the skills and all the devices, and it's all free. You don't have to pay anything to me. This is, I just wanna support our FSU scholars for this intervention and this FNIRS kind of model or quantitative sensory testing. So my lab is focusing on this FNIRS imaging, not only TDCS. Without TDCS, and FNIRS can be used in many ways, like dementia and the cognitively intact person, 2 groups. If you want a 20 dementia, 20 intact people, you want to see those brain function connectivity. That is one possible option. I'm just throwing out my ideas. If you want to go there, please contact me. I will happy to support you. We have our seed money to do this study. So I'm really really think dementia is our next kind of target kind of area. So these FNERs and the TDCS and quantitative sensor testing, especially if you want to use these FNERs, it doesn't need any money. If you want to use our high magnetic lab, it costs good money, I believe. So when I know from my previous institution, University of Texas or University of Florida, they charge me $1,000 for 1 hour. So if you have 2 pre and post, that is $2,000 per person. And if that person is changing their schedule in the last minute because of some, many patients change their schedule several times, in that case, you have to pay them because they already reserved that magnetic facility for your use. So it's very costly. However, these FNERs is all free, and we can do longitudinal kind of level. So you can check this brain connectivity before and after your intervention and follow up. And we can easily adapt their schedule because we do not need any big preparation, unlike fMRI. So my lab is in the Innovation Park. We have a lab manager, the email address or telephone number here if you know more details about it. Or if you want a tour of our lab, please contact me or my lab manager. We will facilitate. Last Friday, the FSU and the FAMU College of Nursing Engineer visit our study, especially for their driving skills. So we are thinking about driving tests, so that how does the driving test change affect those kind of brain function. We are doing with that. Also, this TDCS can be used not only pain, but also the other symptoms. So I will happy to collaborate with you. And again, at least from 1 year from now on, I will not charge anything about this device use or our lab support. And we are happy to support you. We are happy to collaborate with you. So right now we are making partner with the University of Texas Health Science Center Medical School. I'm the adjunct professor over there, and the University of Houston, and the Anderson Cancer Pain Center, Baylor College of Medicine, University of Florida, Emory University. Many people connecting me to use this TDCS or FNERS technology. So I'm happy to share my knowledge and my program for your program research. Please don't hesitate, contact me. I'm happy to share that. And also I've got many funding agencies, NINR, NIA, another NIH, NCRR, Brain and Behavioral Research Foundation. This is really good if you are doing some symptom management research. They are giving lots of research. We got several grants from them. And also all the Adult Independent Center, Sigma Theta Tau, Center for the Cognitive Aging, CTSI, and the Department of Defense and Department of VA. I'm the National Advisory Board for this group, so I know all the mechanism, DOD and the VA mechanism. Please let me know if you want to know more about that. And I think that's about it. So it's a very brief kind of introduction and sharing about my program research, but I'm happy to collaborate with you, and I would like to share all these brain imaging skills, brain massage skills. So please let me know. How can I help you?
Thank you very much, Brian. We had a couple of questions already in the chat session. I don't know if you can access it. They came from Alice. And Alice, I don't know if you want to elaborate or let him read and then he can try to respond.
I think let him read. I don't want to take up more time, and I already asked enough questions in the chat.
We want to leave room for other questions too. Thanks, Alice.
So, okay, let me read the chat box. So, there is a demand, high level of tech, health literacy, and any social demographic data. So so this one does not need a lot of tech literacy because all the thing is they just click on button. That's all they need to do. They just click on button, then it's done. We do the Zoom session, so we kind of see their topology and we give all the directions. The only thing their hands-on things is click the on button. On button is very large. They cannot miss the on button. That's all they need to do. So they do not need any large, like a big, like a literacy, but we are measuring age, gender, possible social demographic data, but do you
Well,
mean?
I guess I was thinking both, there would be factors like different ethnicities do or don't trust devices, which would contribute or subtract from your placebo effect, or level of education, and especially if you're thinking about a dementia population. I mean, my mother-in-law could not remember how to turn on the TV with written instructions, and that was an overlearned skill she'd had for 40 years. So, you know, when you say nobody could miss that button, I am certain my mother-in-law could miss that button.
Yes. So I now I more understand your point of view. The thing is, for my dementia study, is like a dyad study. The dementia cannot itself, they are using our machine by themselves. So the caregiver should be there. So caregiver is the one who clicked the on button. So that for the, since you mentioned about dementia, yes, so that caregiver operate the machine. So did I answer your question about where you're concerned?
So regardless, the person operating the machine still needs a level of tech literacy, and you have experts on that in the room, Neil, with adoption of different computer interfaces and things like that.
Okay, great. Thank you for giving some idea. Geraldine, who is my co-investigator, so I include her for my R1, and she's analyzing our R15 data set. We have, we completed 120 like a samples. Geraldine, that is another good idea. Maybe we can collaborate with Alice to find out any mediating, moderating effect of the education or the other
I'm not the expert on that. Neil is. Whoops, other way.
Yeah. Okay, then Neil. So any collaboration, the more the better, the happier, so that we can see those kind of mediating, moderating effect of this social demographic data, and we will run, and we also have top level statistician, Dr. Hongyu Miao, and we will use that. Okay, then I will go to your next.
Well,
okay.
Before you go to the next question, Brad, Dr. Brad Schmidt had his hand up. So he may have a follow-on to that.
Okay.
It's not a follow-on, but I just had a question. Brian, thank you for this talk. It's very interesting. Super promising line of work. We've done a little stuff. I'm over in psychology. Wen Lee, I don't know if you've touched base with her, but we've been doing a little work with TACS and PTSD, and based on some interesting, findings that we have. But the question that I had for you refers back to the RCT data that you presented. And what I'm curious about is sort of the lack of any kind of dose response effect after your first treatment session. It seemed like you basically were getting a plateauing in terms of those subjective pain ratings. So I'm curious about that, and whether that's also the case with some of the biological parameters, or what you make of the fact that it seems like just one treatment session might be all that you need, and whether you're doing any kind of dose response work because of that.
Yes, so dose response, there is a special RFA for the neuromodulation technique to find out those dosing effects. But that 2016, the first TDCS, we just follow their evidence guides evidence-based guidelines. So we are using single dose, that is 2 milliampere and once a day and 5 sessions, so that we have one single dose. But I'm also very curious about this dosing effect. So that precision medicine, we think that those kind of, we found some people is very, very good results. Some people not like that. But we think something 2 milliampere, that is somewhat safe and somewhat relevant dose. And also those kind of 10 session or 15 session is that. But these are like outlier study or mediating, moderating, those one I'm very interested in. But at this moment, we are not pursuing dosing effect. It's a future direction.
Got it. Thank
That's
you.
great. If I can follow up on that a little bit, one of the other things I was curious about were not so much the dose, but also the location of the stimulation. Because presumably, I guess the mechanism and specific brain regions that are important are not well understood yet. And so one of the things I was thinking of is another control condition that might be helpful is instead of sham, have sham plus not an area that typically is expected to influence pain per se. Or
yes, when this TDCS develops, I'm using primary cortex, so that is C3, C4, and contralateral orbital. So we are kind of stimulating kind of all brain. But when it developed that, if you see, so that evidence-based guideline, I'm sharing that there are actually investing more than 10 different kind of modalities, the different regions. So like dorsolateral prefrontal cortex is one of them, and then visual motor, that is one of them. They think about 10 different regions. Still, among 10, I think 8 studies using this primary motor cortex, because using MRI studies, they have more convincing it affects like pain related, this deep brain structure using that one. So primary motor cortex is now there is a kind of narrowing, but very small. The other group using dorsolateral prefrontal cortex, that effect is kind of varies. So recently there is a meta-analysis, there is finding out, like you said, the dosing effect is one of them. So dose means like a milliampere change, but also these different regions. So there are lots of like studies going on, but at this moment, kind of not a huge consensus, but in general speaking, we somewhat agree to the primary motor cortex, but with a strong theoretical framework, conceptual kind of preliminary evidence, that is another possible for the different neuromodulation kind of modality. It's possible.
okay, thanks. Alice had some additional questions. Was there, because we're running short of time, I know people may have to leave for other meetings. Other questions? Yep. We'll get back to Alice's then. And if people have to leave, please feel free. And I just want to thank Dr. An one more time for a really fascinating presentation, and particularly for his willingness to collaborate with people. And one of the things we were discussing is, particularly as the pandemic wanes a little bit on this particular wave, maybe trying to get a time when a group of people could come out to your lab and take a look at the materials. We'll see if we can arrange that.
Yes, we have resources, we have money, we have seed money, we have all the free access to the machine and technology. Please contact me and our lab, and we are happy to collaborate there.
Sure thing. Okay, any other questions? If not, let's get back to Alice's question about the other 2 points there, if we've got a little bit of time. So the question was, what are the controls compliance with use of other means of pain control at the same time as the device, especially over-the-counter meds like lidocaine, patches, diclofenac, gel, acetaminophen, etc.
Yes, so certain medication, NMDA receptor medication, that is kind of literally affect to that brain stimulation, so we excluded them. But most of my cancer pain project or neoaspirating pain, so they already using those pain medication. So as long as they have like a 3 months kind of usual dose, we do not limiting them. So we included them, and we are kind of modeling those kind of analysis right now. So that's, Geraldine, you can jot down those kind of mediating, moderating effect of social demographic factors, or that counter-effecting of medication as a mediator moderate. That is another good kind of publication in the future. So I like that idea, but at this moment, we included them, and we are using as confounding factors between these two groups.
Yeah, because it seems, especially in your smaller studies, that, you know, if you have one group where most of them are also on narcotics, but the other group is not, for example, or most of one group is on high dose antidepressants, but the other group is not, that's quite a serious confounding factor.
That is correct.
In terms of
And
effectiveness.
we
So
already investigate that, and there is no differences.
When you try to control. Although again, with small sample sizes, it's very hard to kind of manage those types of potential confounds. But now you have a good size sample, it should be a lot easier to track down those potential individual differences.
Yeah. So Geraldine,
so that's actually the medication is a separate issue than the comorbid conditions. So same person, same meds, one has anxiety and one does not. Are those also similar between the two groups?
Yeah. Thank you for sharing that. And we will do more rigorous kind of statistical analysis ongoing right now. So those kind of, I agree with that this comorbidity, social demographic factors, medication that could be possible confounders and mediator moderators, and we will investigate them too.
I'm glad to hear you're doing all those things, because you had to present very rapidly, so I'm sure you have lots and lots of data and stuff that you didn't have time to go into, but some of those major confounders would be super important. So thank you.
Okay, thank you for sharing that.
Any other last minute questions? If not, I want to thank again our speaker for today, and everybody else for virtually coming out to enjoy a very interesting, exciting line of research. And again,